Today we're going to be talking with Dr. Evan Schneider. Dr. Evan Schneider is an MD, PhD, trained in Harvard. He has a very big CV, which I emailed to a lot of the viewers of this channel. And Dr. Schneider is very interesting because he's one of the few people who, on the one hand, has done tremendous discoveries in the basic sciences, but on the other hand, he's very practical in the sense that he sits on several FDA committees, several industry committees, and he's a practicing MD, a pediatrician. So with that said, Dr. Schneider, maybe we can just begin by, maybe you can say how you got into stem cells in general, and then, like we talked about a little earlier, what is it that you believe was some of your major contributions?
Well, why don't I talk about how I got into the stem cell field to begin with, and maybe I'll let the judgment as to what my contributions are be made by the audience. I'll simply describe what I think I was able to, what my own personal journey was in this area. So you mentioned that that I'm also a clinician. And I'd say that my journey into the field of stem cells began before the field was called the stem cell field. And I've actually been in this for a very, very long time, longer than you might guess. I came to this because when I was a resident, a pediatric resident, I found myself taking care of babies who would have injuries, including even strokes. And babies get strokes. And one baby in particular I took care of had a bona fide stroke as a newborn. I saw the kid later on at 9 months of age, and the baby had gotten completely better. There was, even though the CT scan clearly showed that this infant had a stroke, there was no residual damage at all. Maybe just a little asymmetry in the reflexes, but basically the child was off of anticonvulsants, was hitting all the appropriate milestones, and was essentially normal. And I became intrigued with how could this possibly be? How is it that an injury that looks as if it should be so devastating, and certainly would be devastating in the adult, is actually compensated for in this kid? And I asked my professors and my attendings and my supervisors, and they just said, well, kids do that. But I became intrigued to know, how do they do that? Where does this plasticity come from? Because the way we had been taught to view the nervous system for the prior 100 years was that the nervous system was rigid, very deterministic. You lose cells and they're lost forever. You lose a particular kind of cell, it's gone. But yet, here was this plasticity, and if we could find, I thought, the essence of what this might be, maybe this is something we could both understand and then harness and exploit and use in situations maybe where this plasticity failed to exist. So because I was trained not only as a clinician but also as a scientist, I did what good physician scientists are supposed to do, which is go from the bedside to the bench. And I began looking at neural tissue and basically found that, surprisingly and counter to what we'd been taught, there were cells very late into development that had the ability to give rise to many different cell types. And they could be pulled out, and you could grow them, and you could even put them back into the brain. And they would integrate into the brain and recapitulate this kind of plasticity, this kind of ability to not only integrate, but to respond to whatever the cues of the environment were that they found themselves. You could engineer these cells so that they expressed various genes, and they would insinuate themselves in a completely seamless fashion right into the fabric of the brain, acting entirely appropriately, and actually becoming part of the neural circuitry.
And so before I make the question about that, the story with the young child reminds me in many ways of the story of William Corley, the father of tumor immunology. I don't know if you remember, he had a patient, a soft tissue sarcoma patient, who had a very serious bacterial infection, and after that went into remission. And then he dedicated his life to trying to replicate that, and that's one of the main reasons why we have tumor immunology. So it's a very interesting parallel and a very interesting story there. Now, so let me ask the cells, because we do have some very complex people who are going to be asking me this afterwards. What were those cells that you found that you could take out, expand, put them back in, that had the plasticity? In general, I mean, I know there's a lot of cells, but what was the original ones?
Well, so at the time they had no name. These were cells that, and I did not want to make the argument that this was the only source of plasticity in the brain. But I believe that this might be the repository of some plasticity, some resilience that nature endowed to the mammalian nervous system, and maybe even cells like this existed in other organ systems as well. So they had no name, but these are cells that came to be called neural stem cells.
I see.
Because these cells had the ability not only to be expanded and self-renewing, but they could give rise to whatever cell type was appropriate to a particular region, whether it be in any part of the brain or the spinal cord, or even in the peripheral nervous system. So we believe that these were the earliest cell types that existed in the developing nervous system, but that they must persist all throughout life.
Now, so these cells are...
So basically we called them, we came, and I played with all different kinds of names. Neural progenitor cells or neural stem-like cells, and then ultimately simply adopted the name neural stem cells.
And these ones, are they in any particular part of the brain, or they're scattered throughout the brain? I failed anatomy back in college, so...
Well, my belief was that they are present throughout the brain, but that they are enriched in what we call germinal zones. So if you go into, let's say, a developing fetus, I think you would find them surrounding the ventricles, which are the residua of the neural tube, which ultimately is what gives rise to the nervous system. I think in adulthood, you would still find them in the remnants of what are the neural tube, and that certainly is what are lining the ventricles. And then in adulthood persisted the subventricular zone. But I think you will find them in other every organ may have a germinal zone. Some of them are very attenuated, some of them are more robust. But then what we discovered is, because we started looking at the developing primate brain, and we believe that even though these cells are enriched in these particular germinal zones, that they are nevertheless peppered all throughout the nervous system, even the parenchyma, doing various things at an exceedingly low level. But if you wished, you could pull them out, enrich for them, expand them, and put them back in other regions.
My friend Brett Schoeneckes, who is watching this, he was a founder of a company called Stem Cell Therapeutics. They licensed some intellectual property from Sam Weiss up in Canada. And the basis of the company was that in pregnancy you have the surge of HCG, and that the HCG and several other hormonal factors cause these cells in the brain to go out of quiescence. And they had a clinical trial at UCI here in California where they were using human chorionic gonadotropin. Is this similar to what you're talking about? These would have been, I guess, the cells that they were trying to activate?
Oh, I guess perhaps. You know, I think that what we don't know is, and in fact, if you had to characterize after that kind of personal revelation, what I did and what I am doing for the rest of my career, it's trying to understand the language of the stem cell.
The language of the stem cell. Okay.
And that has been my mission. Mm-hmm. What is it that the stem cell is listening to, looking for, and then how does it speak back to its particular organ of interest? And we don't know. I think we're starting to get better at discerning what it is that the stem cell is trying to read and also what it's trying to say. And it is very plausible that looking at various changes in the hormonal milieu is one of those signals. Particularly if you think that changes in hormonal composition accompany certain kinds of pathologic situations. So maybe what I should do is tell you as well what my bias is to the way I view stem cells. So I told you how I came to embrace this as a very important area of investigation. What I also come to believe is that there's nothing magical about stem cells. These are part of fundamental developmental programs. Nature put stem cells there to do two things. One, to put the organ together, to participate, in other words, in organogenesis.
Yeah.
Then to hang on all throughout life in order to maintain homeostasis. In other words, to return a perturbed or disordered system back to equipoise. And to do that, it invokes many, many different mechanisms and many, many different actions. Cell replacement is just one of those many actions that tries to return a disordered system, but it uses many, many other different actions. If you buy that the job of the stem cell is to return a perturbed system to baseline, then it does this often in very subtle ways, often in very dramatic ways, sometimes successfully, sometimes not successfully. But then you have to figure out, if you were nature and you were now going to place in kind of a watchman cell, or a caretaker cell, or a chaperone cell, how would you want it to act? What language would you want it? How would you want it to know when it's time to jump into action or not? And when it jumps into action, what would you want it to do? Would you want it to detoxify? Would you want it to inhibit inflammation? Would you want it to replace a missing cell? Would you want it to promote the growth of blood vessels or to lay down a better substrate? So
no, this is very, very good. Well, there's some chat going on here. Tori and Eunice are chatting about the stem cell. Do you believe that the stem cells in the brain, for example, their role is to basically respond after a stroke? Or do you believe that other stem cell components, such as from the bone marrow, may be implicated in other organs, such as the brain? I mean, specifically, I think what they're talking about, there was a study from a French group showing SDF-mediated mobilization after a stroke, an actual clinical correlation of outcome with CD34 mobilizations. Ones that mobilized more, CD34s, appear to do better after the stroke. Obviously, it was just a correlation study, but do you believe the bone marrow has something to do with the brain, or do you believe that just the brain has to do with the brain?
Well, I think it's a complex answer. I think it's a mixed answer. So first, I believe that the stem cells are playing a role day in and day out. They may be at a very subtle level, perhaps even below the level of detection by the techniques that we presently have. The stem cell is constantly fixing myelin or replacing a substrate or helping a blood vessel get mend itself, maybe even replacing certain types of cells that have become senescent or have died. Under situations of extreme stress, which is what you would consider to be a stroke or head trauma or an infarct or perhaps even an infection, the cells are mobilized and move into hyperdrive. Now, when you have a stroke, many, many things happen, and we have to remember that it is not simply nerve cells that are damaged. When you have an infarct, it's blood vessels that are damaged as well. It's extracellular matrix that is damaged. And it's not, in the neural population, it's just not neurons. It's also astrocytes and oligodendrocytes and various other components. So what I believe is that part of the brain is composed of bone marrow-derived cells normally. We know the microglia come from the bone marrow.
Right.
And in fact, the microglia have received insufficient amount of attention by neurobiologists, unfortunately, but they are very, very critical to this day-to-day functioning of the brain. The microglia are essentially the trashmen of the brain. They are there to remove toxic molecules, or they are there to remove debris, and they play a very fundamental role. And in fact, when microglia fail to play that role, we get disease. There are many of these genetic diseases that are characterized by these engorged, dysfunctional microglia. So in a stroke, for example, there is a breach in the blood-brain barrier. And cells, not only resident microglia that are bone marrow-derived, but also certain bone marrow cells will go to the brain. Now, these are often inflammatory cells. Often they are blood-borne hematogenous cells, and they do various things there. Some of which, perhaps, are to clean out the debris. But then what they also do is they set up signals. And these signals then bring in other waves of cells. Some of these cells are the neural stem cells. So I think it's very curious, in fact, and prior to the show we were talking about what are the common themes across organ systems and across stem cell types. Well, the fact that stem cells home to injury or pathology, and we call this pathotropism, that they do it in response to inflammation. And inflammation is characterized by a whole rich panoply of inflammatory molecules. It so happens that some of these molecules are common across systems. SDF1 alpha and its receptor, CXCR4, seem to characterize many of these organ systems, and many stem cells respond to them. In fact, many years ago, we found that after a stroke, the damaged brain, as opposed to the intact brain, upregulates SDF1 alpha. And then the neural stem cell begins to upregulate its expression of CXCR4 and moves to where that is. Who presents the SDF1 alpha? Well, it's kind of interesting. The SDF1 alpha is presented to the neural stem cell by 1, reactive astrocytes, but 2, inflamed vasculature. Well, the vasculature does not come from the brain per se. It comes from mesoderm. These same signals, however, probably also draw cells from the bone marrow to go there. I don't think the bone marrow cells literally become neural cells. I know this is very controversial. I don't think that's what they do. But they do then speak to the neural stem cells to do these various things. And it's actually almost a poetry of how an injury, without nature having to micromanage it, can begin to pull in cells that do various phases of what you would want them to do to try to first clean out and then protect and then try to rebuild a damaged organ. It may not do it the way we would like. It may not do it effectively or as effectively as we would like, but it does try to do it.
So this is 2 quick questions. Number 1, anatomy is not my strong point, and neither is biochemistry. When you mentioned that the SDF1 alpha is presented, what do you mean? You mean it's actually put on an extracellular matrix, or what did you mean by that when it's presented?
By presented, it means that the SDF1 alpha then is expressed on the surface of the astrocyte, which is a cell type, or actually presented on the surface of the blood vessel, the vasculature.
Okay, so it sticks. It physically sticks on...
Or it itself has the ability to make this molecule and then presents it.
I got it, okay.
Now, what becomes even more fascinating is that we all think of this example, and I want to emphasize that CXCR4 is the receptor and SDF1 alpha is the ligand, are simply one representative chemokine and chemokine receptor ligand. There are many, many, but it's a very useful, valuable, and very important pairing. We think of them as being inflammatory, and in fact, their initial origin and their first characterization was by the hematologist, particularly the immunologist working in AIDS. What we learned is that it is not just in the province of the hematopoietic system. Obviously, it's present with neural injury and neural stem cells. But what's fascinating is that these exact same molecules during the earliest stages of brain development are responsible for neural stem cells in the embryo, in the fetus, moving up from their germinal zone to the right stage in the brain. So in other words, this same molecule that dictates movement in injury plays a role in migration in the actual formation of the proper layers of the brain during normal development. Then those molecules recede, they become quiescent, they disappear until there's injury. So nature then reinvokes them again, which has this very appealing notion that when nature has a strategy that works well, it reinvokes it time and time again, and that actually repair may be nothing more mysterious than nature trying to reinvoke developmental biology yet again. Trying to reseed the lawn. Or reboot the computer.
And then you take
same cells, same molecules, maybe even some of the same actions.
And then you take it to the next level, which is in a cancer. And you see a lot of these things being... this is very exciting, and I do have a question about that, but something very interesting that came up in the chat. And I saw in your CV, I skimmed it, that you also studied philosophy and linguistics to some extent. Memories, when people make memories, what happens? Are new neurons, a naive question, but I didn't know the answer either. Are new neurons being made, or are the old neurons just switching the connections? Is there a stem cell component to memory formation?
Oh, you have asked one of the most vexing questions in all of neuroscience.
Eric asked, not me. Eric from the chat.
It is not only such a terrific question, it is the question that keeps neuroscientists up at night. And based on where you come from in terms of why you've become interested in the brain, you have a different answer. So on one extreme, you have people that embrace the total plasticity of the nervous system, and they believe that anything can be fixed and things are exceedingly fluid. And to an extent, there is a great degree of plasticity. But then on the other hand, you have those that still, despite the advent of the stem cell field, believe that there must be some rigidity to the brain, because why don't we lose memories? And if it was too plastic, wouldn't we lose memories? And how is it that you can have new cells being born that integrate into circuitry, but you don't have to relearn language? You don't have to relearn your knowledge. It's there. How is that preserved, yet we know that there's new neurogenesis even in the adult brain, even in the hippocampus, which is meant to be the organ of memory formation? In all honesty, we do not know. There must be something that is the inheritance of the brain that is immutable, superimposed on an aspect of plasticity that nevertheless is changing all the time. So the short answer is we don't know, but that is what keeps philosophers and neurobiologists up at night all the time. And since I'm both, I get no sleep whatsoever.
Well, the question, let me take it down to a really, I don't want to use the word stupid, but I'm going to say something really stupid right now. Let's say that I sit down And I try to memorize, for example, this book here. But before I started trying to memorize it, I started injecting myself with BRDU. Am I going to see more proliferation somewhere in my brain? I mean, well, not me, but I'm saying somebody must have done these studies with water, with mazes and stuff like that. Is there more proliferation when you make an animal memorize more in any area of the brain?
So I think the simple answer is yes.
Okay.
That there probably is more proliferation. And we certainly know from not BRDU, but now that functional MRI is around, that we do know that when various tasks take place, that there's greater activity in certain regions of the brain. And certainly some of that activity can be increased proliferation. But I think we also have to become more sophisticated in the stem cell field to realize that stem cells can be mobilized into action in ways other than simply re-entering the cell cycle.
Okay.
We think that they can become, certainly they can proliferate, and that's what the BRDU would pick up, but I think they can start becoming more active. They can start reawakening certain circuits. They can start maybe starting to communicate certain molecules through various ways of communicating. And if they need to change, we think that maybe they can even begin to start sending various kinds of genetic material from one cell to the other, perhaps even doing little bits of reprogramming of neighboring cells or even reprogramming themselves.
Now, this is something very, very controversial. I mean, I was at the ASH meeting, and I saw Peter Quisenberry. I don't know if I'm pronouncing his name right. He's the
Yes, I know Peter very well.
And he had a poster, and my jaw dropped, if I understood it correctly, which he had injured lung tissue, injured liver tissue, and I forgot some other tissue and control tissue, and he was transferring the supernatant on bone marrow cells, just heterogeneous bone marrow cells, and he was showing the supernatant would induce a differentiation towards that lineage. Not to get into that whole argument, hematopoietic plasticity, but what shocked me the most is he was saying with a straight face that is microvesical transfer of genetic material from injured tissue. And viewers of the show will know that I've done some work in the area of exosomes, immunology of exosomes, but more recently, people have been talking about horizontal genetic transfer via exosomes. Now, I don't know genetics either that well, so please tell us, is there any evidence that horizontal gene transfer exists?
Well, obviously this is a very, very complex situation and concept. What I can tell you is what I do know. I think we'd be naive to believe that the only action of a stem cell in trying to return a disordered system to equipoise is that it has to re-enter the cell cycle, divide, and become different kinds of cells. There are probably many other mechanisms. Now, what we do know is that, in fact, one of our contributions to the stem cell field was what we call the chaperone effect. And that's the notion that stem cells can help promote recovery by means other than simply replacing cells. What they can do is they can protect threatened or dysfunctional host cells. They can change the niche. They can change the milieu. Now, we had always believed that the way that they do this is solely through soluble factors. In other words, diffusible factors that are made by the stem cell and then diffuse over and kind of bathe the endangered cell and rescue it, and presumably trophic factors and things like that. Just last year, we found that the stem cell can participate in this chaperone effect by mechanisms other than diffusible factors, by literally through cell-cell contact. Now, the cell-cell, what happens is the stem cell makes cell-cell contact with an endangered nerve cell, for example. creates and makes a gap junction. Gap junctions are channels through which molecules of a particular size can be transferred back and forth. Now, when these cells make gap junctions with the endangered cells, the stem cell rescued the endangered cell. And they did it by the creation of gap junctions. And if they were prevented from making the gap junctions, the entire rescue effect was lost. Now, we do not know what is transferred through these pores, through these gap junctions. We think it's molecules that somehow reorder the disordered internal milieu and metabolism of the endangered cell. We think that it is even molecules that improve mitochondrial function. However, once you accept that molecules can be transferred through these gap junctions, we begin to know now that certain things can pass through gap junctions that are not simply these various kinds of growth factors or trophic factors or molecules of a particular size. We know that even RNA and DNA and small molecules and microRNA can be transferred through here. And if you accept that, then you might also begin to accept that what is this genetic material doing? Maybe it is doing a reprogramming of some sort, and the reprogramming, the intent of the reprogramming is obviously to make the cell function better, either to become more resistant or to maybe take on a particular identity. So this is pure speculation that I'm giving you now, simply based on this observation that gap junction formation is pivotal for the chaperone effect and for even laying down more mature intercellular connections.
Now, let me say this, because some of the people, like we were saying before on the show, some of the people accused you of being a hater and putting down certain areas. Now, now I'm going to be a hater right now and ask this question. The physiological relevance, in my mind, I'm seeing a stem cell, and there's, what, 1 in 100,000 is a stem cell compared to the somatic tissue. Does the stem cell feed off into many cells to make these gap junctions, or how would be the in vivo relevance of this? I don't really see it in my mind.
Well, I can't honestly say that that I can say that this happens in the intact organism all the time in vivo, though I believe it might. The observation I was telling you comes purely from transplantation experimentation, or from looking at slices of brain, where some of the endogenous stem cells will do this. But if you ask me to come up with a scenario where this might work, I think I could do that. I think that probably would involve stem cells perhaps self-renewing a bit and moving to various areas.
There was 2 papers with exosomes that shocked me, that they showed when you take mesenchymal stem cell exosomes and inject them in the cardiac infarct model, you have accelerated angiogenesis and cardiogenesis. So it might be, maybe exosomes have something to do with it. I don't know.
Yes. No, I think that we would be naive to believe that we know all of the strategies by which cells communicate with each other. And even more naive to believe that if we've identified other mechanisms by which cells communicate, that stem cells at some level might not also engage this kind of mechanism to do their job.
You know, this concept, though, you might be too young to remember this, but a long time ago, people used to believe, in my field in immunology, that there's something called immune RNA. Before we discovered the MHC T cell receptor, that an antigen-presenting cell would reprogram the T cell. And the basis for this was that if you immunize an animal with a model antigen, then you sacrifice the animal and transfer proteins to a naive animal, you wouldn't have memory. If you transfer DNA, obviously you wouldn't have memory. If you transferred RNA, their RNA fraction, you could transfer the immunological memory. And these studies were repeated in numerous different independent laboratories. So maybe that has something to do with it as well. The most interesting with this, why I mention it, why you made me think, is that And tell me if this is correct, because maybe I imagined it, that some of the early studies with memory in the worm, that they could also transfer the memory in the worm with RNA. Is that true, or do you know anything about that?
Yes, I've heard about that. And I think now we're moving into the realm of a little bit of MediStem cell biology and science fiction. But I do think that we should always be using our imagination, be exceedingly skeptical, critical, rigorous, and even when we have an idea, come up, most importantly, not with why it's a good idea, but all the reasons why we are wrong. But having said that, there are many things happening in the stem cell field that we would never have predicted are possible. And one of the things that I'm thinking about is this very notion that a mature cell can be reprogrammed to take on a different identity. Right now, the entire stem cell field is intoxicated with this notion of induced pluripotent stem cells. Had we thought about this a decade ago, we would have said that this is impossible. But the fact is that one can do that. Now, we don't know what's going on. We don't know why it happens. And in fact, if you think back to the history of biology, we've seen various examples of this before. We've been aware of these heterokaryons, the fact that you can take a nucleus and put it into another cell and change the identity of that cell. We've been familiar with cell fusion. It's not entirely foreign to us, but the very fact that it can be done with defined molecules and so relatively efficiently, even given how inefficient it is, makes you challenges some of our beliefs about the rigidity of development. Now, being stem cell biologists, we should not be surprised because the very field of stem cell biology challenged the rigidity of the body. And certainly in agriculture, we've always known that you could do nuclear transfer. But if you believe that something that we do in a dish is not all that different from what nature might do at some exceedingly low level day in and day out, what I'm intrigued about is, are there examples of where nature uses reprogramming to do its bidding, to introduce various elements of plasticity? In fact, we could even, you went back into your deep past about immunological RNA. In some respects, and again, I'm being a little bit philosophical, is there right now, can we make the distinction between what we now call induced pluripotency and the notion of reprogramming cells with oncogenes, and what used to be the 1980s concept of oncogenesis? Now, back in those days, too, we used to think about a normal cell moving back, becoming de-differentiated because it had the overexpression of certain genes that endowed it with self-renewal, maybe even inappropriate self-renewal, and the ability to do various things. So that's now, of course, all of us can come up with differences between what is a cancer and what is an induced pluripotent stem cell. I'm not talking about the extremes. I'm talking about the Venn diagrams where there's a huge amount of overlap there. Now, that's an example of some reprogramming that may be pathologic, and that maybe is what we call cancer. But are there examples, again, even below our level of detection, where maybe reprogramming in some way is also one of the actions of the stem cell? And maybe cell fusion, even though we came to see it as an artifact maybe 5 or 6 years ago, is maybe on some level cells fuse with other cells, reintroduce new genetic material, reprogram cells, and that someday we will learn that that too is one of the actions of a stem cell to try to reorder a disordered system.
Well, you know, that's very, very interesting because the company that I work for, MediStem, we have an IND in front of the FDA, and right now it's on clinical hold, and we're giving a response. These are stem cells from the menstrual blood. And as part of the response, we did a comprehensive literature review of the use of mesenchymal stem cells in general, and then we're going into some of our clinical data and so on. One of the things that really surprised me is the use of mesenchymal stem cells in bone marrow transplant. If I understand it correctly, you very rarely find donor mesenchymals taking in the bone marrow of the transplant recipient. However, you do see a lot of studies showing female recipients of male bone marrow transplants having Y chromosomes extensively in areas such as the heart or the liver or even the uterus. So maybe that's one of the examples of what you're talking about. I mean, I'm not saying it's definitely the mesenchymal component of the bone marrow that's doing it, but there's these weird kind of cells. I'm sure you know about them, this VSEL, that very small embryonic-like. What's the deal with those? Are those leftovers, do you think?
Yes, I've heard a number of talks about them, and I have to confess, I really don't know what to make of them. I don't know what they are.
Yeah.
But to get back to the point that you were discussing before, Helen Blau and I have known each other for many years, and we've talked about this notion even though cell fusion, when interpreted in the wrong way, can lead to wrong conclusions, it does happen. And it seems as if cells, for example, from the hematopoietic system or from the bone marrow, do have a propensity to fuse with neural cells. And they seem to do it, and other cells as well, but they seem to do it most under conditions of inflammation. One could envision a scenario where this is a way that a healthy cell might go to an endangered cell and try to transfer genetic material to make that endangered cell function better.
Wow, that's really cool to think about.
Now, the problem, of course, came when this strategy was used to misidentify a cell as having come from a blood cell. And, of course, we all know the story was that it was because of the transfer of genetic material that there was kind of a misassessment of who came from whom.
Yeah.
But nevertheless, the very notion that a cell does fuse with another cell and transfers genetic material is exceedingly intriguing. I guess we've now really ventured into areas of heavy speculation, which is always fun but dangerous. But I think the take-home lesson really is to try to keep an open mind about stem cells, not in that these are pixie dust that you just sprinkle and that they magically do things without our having to understand the biology. I think that's not what I mean.
Yeah.
What I mean is that nature has endowed organisms with cells with an enormously intriguing repertoire of behaviors, some of which we've only begun to understand, but all of which I believe has the intent to, one, participate or even drive organogenesis, but then also to maintain the health and well-being and lifespan of an organism, and it does it in many different ways. And some of these new areas of cellular communication, I think, will become areas of heavy investigation in the decade to come.
No, I
think it's going to be more. It's going to be more than simply that a stem cell makes these identified trophic factors and that bathes the endangered system. I think that's intriguing. It's important. It's true, but that's actually already well-plowed territory. I think now it's time for us to think about how else can the cell talk to its environment.
Now, let me ask this quick question, because we're talking about the natural order of things and natural cells in the body. For me, the IPS was a very simple discovery in a way. I mean, I sat down with my quest numerous times, and he was saying to me, look, we have the whole transcriptional profile of every cell, and we have the embryonic cell. So we compared those. We saw genes that were always expressed in embryonic cells. We transfected them, and we saw dedifferentiation. Now, my understanding is the starting cell that you're putting the genes in, the more undifferentiated it is, the easier you're going to get IPS, more or less. So here's my question to you. In the thymus, the thymic medullary epithelial cells, these are the only cells in the body that can express almost every single transcript that will ever be expressed in the body. For our viewers, it's a very, very interesting story, not to detract too much. Diane Mathis and Charles Benoit, I believe, from Harvard, found out there's a gene associated with autoimmunity called AIR. And they found out that people who have a mutation in AIR have all these systemic autoimmunities. So then when they looked at the animal genetics, they found out that AIR induces promiscuous transcription in the thymic medullary epithelial. This is why you get thymic selection when you are a baby. When you are an adult, you have all sorts of other proteins that your thymus has never seen, but they're still deleted. Has anybody talked about or thought about making IPS from thymic medullary epithelium? Do you know?
I am not aware of anybody doing that, but I bet you after this conversation, there's going to be a number of people going back to their labs right now and starting to do that.
Or filing the patents.
That's right. Well, maybe this counts as public disclosure, so now they can't do it. Because
exactly. I give that one as a freebie. No. Okay.
But you know, what you've raised is an interesting question, which is... we've always thought of the continuum of stem cell biology as moving left to right. In other words, from exceedingly immature, and that at each stage the stem cell learns a little bit more about the address where it's meant to be living. And we move from exceedingly plastic all the way to fairly committed. And now with the IPS field, we've learned that that we can also start moving backwards. So the continuum also goes from right to left. Mm-hmm. The question now becomes, if one is translationally oriented. Yep. So now I'm going to talk about translation. Uh-huh. And let's say, for example, that you want to cure a brain disease. Yep. Do you need to go all the way back to pluripotence if what you really want to do is treat a brain disease?
Yeah, exactly.
Do you need to take a cell that's so irrelevant to the nervous system, push it all the way back to pluripotence where it can give rise to every single cell, simply to instruct it to go back to become brain again? Yeah. Maybe now that we've accepted that this is a great thing that one can do, that you don't need to have necessarily these amazing swings of identity in order to have something that's useful. Maybe it's simply sufficient to take a cell that already knows its want-to-be nervous system, to take a neural progenitor cell, and now all you want to do is to be able to expand it, allow it perhaps to, have a number of identity choices. So now you simply want to endow it with self-renewal so that you can expand it and put it in various regions. Mm-hmm. So maybe the reprogram doesn't have to be these huge swings, but simply now going to your organ of interest, allow one to expand it. So now, even if it doesn't naturally self-renew, just put in a self-renewal gene, maybe even a regulatable self-renewal gene so you don't cause problems, expand it, and then put it back.
Yeah. No, This is we had Meet Patel and Warren Sherman. We were talking previously about Eduardo Marband's work with very similar what you're saying in the heart. A couple of questions that these guys are going to get mad at me if I don't ask, because they keep asking. These are going into politics, I guess. And, we don't really do too much politics on this show, but.
Well, we did philosophy, so we might as well do politics now.
Well, exactly, and we should start drinking too. No. Let's see. There was one here. Okay. It's up here. Why is ISSCR? First of all, what do you do for ISSCR? I don't even know. I didn't read everything. Are you affiliated with ISSCR?
Yes, I am. I do a few things. I'm on the editorial board of one of their journals, which is Cell Stem Cells.
Oh, great.
I'm also on the editorial board of another one of their publications, which is called Current Protocols in Stem Cell Biology. And then I also serve on one of the committees that is designed to vet any kind of clinical trials or any use of stem cells in patients, and then try to inform the public as to whether the clinical use is justified by data or not justified by data.
Excellent. Because this is the question is, why is ISSCR insisting on level 1 evidence for stem cells when about 80% of medicine surgery has no level 1 support? Why do stem cells need more evidence support than exists for arthroscopy or rotator cuff surgery? I have my personal opinions on that as well, which I'll just say them because
yes, please do.
Obviously, part of it has to do with the fact that the stem cell is going to be in your body, arguably for the rest of your life. So that's obviously a very big concern. But anyway, tell me. They asked you, not me.
Well, because I think that the potential for doing damage is quite real. One is putting cells in that conceivably can change the makeup of the recipient organ. They can create cancers. They can create inappropriate cell types. Now, one could easily make the argument that somebody sticking a scope into the wrong place could be doing damage. And I have to tell you that I'm of the opinion, and as a clinician, I deal with a lot of individuals that do that do experimental therapies that have nothing to do with stem cells. And I'm of the belief that it's not that stem cells, that the regulation of stem cell use should be relaxed to equal that of various kinds of surgeries. I actually believe that those doing interventions in the hospital that don't have level 1 proof should probably not be doing it, and that they actually should be held to the same standard that stem cell biology is held to.
But I think, I should qualify what I said in some way, because I believe politically the word stem cell therapy means so much. You remember, maybe you were even part of those studies, when Latent Biosciences was taking cancer cells, differentiating them into neurons, and implanting them in the brains of people with stroke, I think, and that got FDA approval. The trial did. Now, that's a very extreme example. What is your opinion, the questions here, with the autologous bone marrow and some of the uses of autologous bone marrow? And I don't know if you can answer this, but can people do autologous bone marrow in the U.S. for heart failure, let's say, or what? This whole homologous use. What do you think in general about all that?
Well, actually, they can. If the cells are minimally manipulated. So let's say I assume that they're talking about autologous bone marrow derived cells. If they are minimally manipulated and not genetically altered, one does not need FDA approval to be able to do a study with those cells. Now, if you do it in a hospital, you may need your own hospital's IRB approval.
Right.
But you don't need FDA approval to do that. Now, what I'm saying should not be misunderstood. I'm not saying that people, investigators, and clinicians should not be trying imaginative and cutting-edge therapies. But I believe that they should be done in a way that the outcomes can be interpretable.
Exactly.
So they should be done in a very rigorous, carefully studied, carefully controlled manner so that the outcomes can be interpreted, so that one can tell whether the intervention was or was not useful. So that so that not only can you figure out whether the intervention was useful, but if it was, let's say, 50% useful, you can figure out how to improve the efficacy or how to improve the safety. So I am not in any way opposed to clinical trials, even those that may be a little bit creative or departing from what we are able to do from a basic science point of view. As long as the scientists are blinded, as long as the outcomes are rigorously put in place and are objective and quantifiable, and the patient population group is well informed and somehow homogeneous, then I think that is probably okay.
No, I agree. The question here is, the U.S. will no longer dominate science and research. I already see this is happening with actual treatments at offshore clinics. Patients are growing weary of waiting for the U.S. to move forward, even with simple autologous treatments.
So let me make sure I understand the question. The question is that patients are becoming frustrated with the United States because they feel that that either the regulatory agencies or the scientists themselves are just dragging their feet or moving too slowly or waiting for ideal knowledge.
Yeah, I think that's what they're asking.
Well, I think that the United States is doing it the right way. I think that the history of medicine has actually been littered with therapies that have turned out to be non-helpful, non-useful, sometimes even dangerous, and that we now have come to kind of to relinquish as part of our armamentarium. And that includes even various kinds of therapies that used to be the mainstay of intervention. So let's not even talk about therapies that are cutting edge and out there. For many, many years, we believed that we should be doing carotid endarterectomies. Yep. And we subjected many, many patients to this. Well, we learned, in fact, that it was not doing the right thing for many, many patients. It was not getting rid of stroke because that's not what the problem was. And in fact, was placing certain patients at risk. And if nothing else, was subjecting them to a surgery that was unnecessary. This is the same thing has happened with doing back surgery for discs, or doing various kinds of cabbages and things of that sort, or doing cesarean sections for various kinds of pregnancies. So much of medicine, the history of medicine has had many interventions that were initially felt to believe rational and informed by logic, that turned out not to be the case. And in fact, when they were investigated, we learned more about the disease. Our knowledge of the disease became more sophisticated, and then we stopped pursuing this kind of therapy because it no longer made sense. I think, however, that the only way that science and medicine can make progress is to constantly be skeptical, to constantly be introspective, and to constantly hold every therapy to a very, very high standard. I think that is the way that you make progress, both in increased efficacy and increased safety. So I actually believe the United States is doing it right.
Let me ask probably one of the last questions on this theme from ICMS. So he is saying that we can't trust doctors to treat patients. Is that what you were saying?
Is the question whether we can trust doctors to? Well, I think it depends on why a doctor has gone into his field. I think that if a doctor has gone into the medical profession to make money, then I would agree that maybe the motivations are suspect. If you have a physician who's gone into medicine because it's a calling, it's a passion, particularly if they've gone into academic medicine. And I can tell you, I am a pure academic, and I've taken my vow of poverty that I think one can trust their motivations, because I, like many of my colleagues, approach medicine as a field of scholarship.
Yeah.
And that is why I do what I do, because I view myself as a scholar of the human body, and because ultimately I want to, heal people. In my particular case, I'm a pediatrician, so I want to improve the lot of the next generation of the world's citizens.
Yeah. No, that makes sense. Let me really quickly, before we summarize, maybe I can say a couple of words on some of my opinions, because I think maybe the people who are talking on these stem cells and adult stem cells and this whole controversy, maybe some of the right questions were not being asked or not being put forward. I believe that the stem cell and a lot of the controversy comes from the point that bone marrow is a very simple and easy procedure. And we've identified, by we I mean as a discipline, a lot of fantastic things that bone marrow infusion can do. They're very straight at the clinical level. And I don't know what the questions were being asked here, because they were not, I think, touching upon the big problem. The big problem is this. And please, I want people's inputs and your input. When this work was being done, when Orlik and others were showing that you give GFP bone marrow into the heart attack and you see green cells, which I guess we found out the fusion later. You had a lot of great work being done in Japan, in Germany, and in the U.S. by some of the people who were on the show previously. There were attacks made that a bone marrow will only become a bone marrow cell. And I think somehow the message got mixed up, because what you were saying is if a bone marrow cell is fusing with an injured cardiomyocyte, or if it's transdifferentiating, that's really an academic argument. If we see improvement in quality of life and in ejection fraction in placebo-controlled double-blind phase 3 trials, I don't think the patients really care how it's working. But what happened is, and I really love your opinion on this, because maybe I'm missing something. What happened is you had different people start doing these procedures, which are relatively simple to do, some of them, and they started doing them offshore. Now, there are charlatans offshore, of course, but there's also, I believe, some really good people that do bona fide GCP grade clinical trials. But I think what ended up happening was you had this discord that ended up getting amplified, and then, because you know ISSCR more than I do, then what ended up happening is some of the people who have been doing work offshore started saying, why is ISSCR an organization that's primarily studies mechanisms going after clinics without having MDs who do clinical trials as part of that committee? And I think that's how the whole argument, and I think some of the people were trying to get to that, but they didn't really explain it. So what is your opinion in general about these things?
Well, my opinion is that I think that a practitioner who proposes to have a particular therapy for a particular disease should be intellectually curious enough to understand the mechanism by which it's working to the best of his ability, and not try to fool himself or fool the public. So I'll give you a particular example from experiments that we've done. With regard to doing bone marrow transplantation for myocardial infarction, I think that it would be wrong for a clinician to say, I am going to do this because these bone marrow cells are going to become heart cells. That would be wrong. Now, if you were to say, well, when one does bone marrow transplantation in animal models, I do see that under good, rigorous situations, some of the animals function better, the heart functions better.
Mm-hmm.
I then believe that what he should do is say, why is this happening? Why is the heart functioning better? And then he might find the answer to be the following.
Mm-hmm.
Well, the stem cells are not necessarily becoming heart cells, but they are having an anti-inflammatory action. Maybe that's what's working, and then investigate that. They're not becoming heart cells, but they're promoting angiogenesis. And that helps because it's now reperfusing an area that was poorly perfused. Mm-hmm. Or they're not becoming cardiomyocytes, but they are becoming the interstitial cells. And the interstitial cells are preventing scarring, and preventing scarring maintains the size of the heart and maintains Starling forces, which means that cardiac output seems to be better, or at least preserved. So I know the mechanisms why I'm seeing it. It's not the simple explanation, but this was sufficient for me to see an outcome. And then if this is an investigator or a clinician who wants to use this for patients, he then will say, this is the therapy, and this is why it's working, and this is why we're going to do it. And then importantly, he would have to demonstrate, and this therapy is better than standard of care or present therapy. It's better than using a diuretic and ionotropic agents and changing your diet. It really works. If somebody went through all of that, I have no problem, and it was really done in a case-controlled, double-blind manner with good objective outcome criteria, that would be fine.
Yeah.
So, do I have a few minutes to tell you?
Yeah, absolutely.
An example of where this is very, very pertinent because it was told to me. I mean, you actually said that there's a belief out there that Evan Snyder hates umbilical cord cells.
Yeah.
Well, let me address that because I've had an opportunity to actually study these cells in collaboration with Joanne Kurtzberg, who is a true expert in the use of umbilical cord cells, actually in patients, not just in animals.
Yeah.
And just even before I tell you this little story, just to demonstrate that I do not hate umbilical cord cells, I can tell you that I have two tiny kids, and I banked both of their cord cells. I personally banked my kids' cord cells, but I'll tell you why I did it and with what intent. So, and we've not yet published this, so I'll simply describe it. But Joanne and I will publish this shortly. As you know, she is very active in doing umbilical cord cell transplantation in the context of bone marrow transplantation for kids with inherited degenerative diseases, like some of the lysosomal storage diseases. Yeah. And she actually had some very intriguing good outcomes in kids with a very rare disease called Krabbe disease. Yeah. That goes under the name also of globoid cell leukodystrophy. It's a lethal disease, and the enzyme that's missing is called GAL-C, and it's a horrible disease. It's one of these leukodystrophies. And she had actually found, in fact, that if she did an umbilical cord transplant in these kids within their first 2 weeks of life, that the kids actually did better. If she missed that first 2-week window, she really did not have a clinical outcome.
Myeloablative? This is myeloablative? No.
And it was, yes. It would be. Okay. She would do a proper bone marrow transplantation. She would match the cells to the recipient.
Gotcha.
She would do a chemical ablation. And it was a very, very well done.
Yeah.
Well, I said to Joanne, because we started doing this in the days when it was still uncertain whether umbilical cord cells could become nerve cells or could become other kinds of cells. I said to Joanne, have you ever had a situation where a kid has died, where you actually have the brain that I can examine?
Yeah.
And In fact, that was the case. She had a few of these brains, and one in particular. And very opportunistically, the child who received the transplant, and the child had Krabbe's disease, was a girl. The cells that were being used for the bone marrow transplantation, the umbilical cord cells, were male, which meant that we could now completely identify who was recipient and who was donor. We also, or I also believe, coming as a stem cell biologist, that this would be the perfect situation. This is a young brain that actually had some damage. So if you believe that damage would promote change in differentiation fate and migration and things like that, this was perfect. The cells were optimally matched. The bone marrow would be ablated, and the cells would be in the brain for an exceedingly long time. So if there was ever going to be change in fate, this is where it would happen, because in this particular case, the cells were in the brain for about a year, which is a very long time. Also, we knew that the patient experienced excellent chimerism. The baby's blood type the baby's bone marrow was now composed of donor cells. And in fact, many of the blood-borne cells did have the donor characteristic. In other words, they were male cells, white cells and things of that sort. So we looked at the brain, and it's a very interesting situation. It's maybe a good news, bad news kind of situation. Oh, and I should also mention that the reason, unfortunately, that the child died after a year was the child died of a pulmonary complication, so died a pulmonary death, not as a result of the transplantation or anything of that sort. The umbilical cord cells in the brain made it through the blood-brain barrier. They were all throughout the brain, stem to stern, and they were in the gray matter, in the white matter, and maybe they were a little bit more heavily concentrated around blood vessels, but they were present all throughout, and they were sitting next to host cells. That was good. That was we never knew that was actually the case, and to this day, nobody really knows whether the cells actually made it into the brain. And the answer is they do. They're all throughout the brain, and they last for at least a year. What did the cells become? They never, even if they were in the white matter, they never became oligodendrocytes. Even if they were in the gray matter, they never became nerve cells, neurons. They never became dastrocytes. They never even became immature neural cells. They never became anything that was of the neural lineage. Does that mean, however, that they did not serve a function? Actually, they did in this kid's case. Remember I said that the other name for Krabbe's disease is called globoid cell leukodystrophy. They're called globoid cells because, or the disease is called globoid cell leukodystrophy because the hallmark of this disease are globoid cells. These big, huge cells that are just filled with debris and all kinds of storage material. This kid had no globoid cells in her brain. This hallmark of this disease had been totally eliminated. Why was that happening? We realized it was happening for two reasons. One, the umbilical cord cells, even though they were not becoming nerve cells, they were going into the brain, all throughout the brain, and they were bringing in the missing enzyme, GALC. But also, they were becoming microglia. Microglia are derived from the bone marrow. They go to the brain, and as we had talked about earlier, the microglia play a very important role. They are the trashmen of the brain. And now, as opposed to the kid who had abnormally, poorly functioning microglia, now the brain had good functioning microglia with the proper enzyme that was now eating up the storage material. So what's the take-home lesson? The umbilical cord cells were doing something. They were bringing in missing enzyme. They were now putting in excellently well-functioning microglia, which are very important for normal brain function.
Yeah.
So the cells played a role. Why would I use umbilical cord cells now? Why did I even preserve my own kids' umbilical cord cells? Well, if I ever needed to do a bone marrow transplantation for enzyme replacement, if I ever wanted to endow their brains with good functioning microglia, and we're starting to learn that microglia functioning normally are incredibly important for normal brain function. And of course, if I ever needed hematopoietic stem cells, and we can all imagine situations where throughout life we would love to have hematopoietic stem cells to be able to give us red blood cells and white blood cells and platelets in situations maybe where they are in short supply, for example, during an accident or where we don't have a good match, where I would not advocate using umbilical cord cells, and I would say that it would be misrepresenting their potential to customers or to patients, is to say, well, bank your umbilical cord cells because they're going to become neurons when you develop your Alzheimer's disease, or dopaminergic neurons when you develop your Parkinson's disease, or they're going to replace nerve cells when you get stroke or head trauma. That would be a misrepresentation of the data, and I would vigorously oppose selling that to patients.
No, right, but I think, because some of the people on the chat here are arguing and trying to figure out if you hate them or like them. The point you're making, the point you're making is that you shouldn't be selling them on a mechanism or this beautiful, simplistic concept of cord blood becoming brand new tissue, but you are saying there's some clinical concept that they may have a benefit. That is what you're saying, right?
Yes, what I am saying is like any mechanic, you use the right tool for the right indication.
Yeah.
You don't use the wrong tool for the wrong indication. If you're a clinician, you don't use digoxin to treat pneumonia.
Yeah.
You use penicillin. And you would never say, I'm going to use digoxin to get rid of your pneumonia. Conversely, you would never say, I'm going to use penicillin because you have heart failure. Simply be honest and upfront and knowledgeable about why you're going to use a particular therapy for a particular indication. And that's all I'm saying. And I would say, actually, I do not hate umbilical cord cells. In fact, what these experiments, what the study taught me is that there is a proper use and a very important use of umbilical cord cells, and I will use it for these indications. I will use something else for another indication that is better suited to that need.
No, this is very last question, I guess, before we get going. With this, or two quick questions. So with this Joanne Kurtzberg, she was doing cerebral palsy autologous. It's no damage. I mean, I guess it was damage, but did she ever do a trial on that? Is she doing a trial? Because I remember they were doing it as autologous, but under practice of medicine or something like that. Do you know if she's?
One of the trials that I know she's doing is to use umbilical cord cells in newborns who have undergone acute hypoxic ischemic injury.
Right.
And I think that it's unclear whether that will be useful or not. I think if the intent is to use those cells to inhibit inflammation or for certain aspects of neuroprotection or to preserve blood vessel integrity, I think that may have a rational use.
Yeah.
Where I would not use umbilical cord cells is outside of the acute insult situation. I would not use umbilical cord cells in well-established old cerebral palsy. So I would not use them in the situation of a kid who has acquired cerebral palsy and has had it for, years. Unless, of course, it turned out that the cerebral palsy was misdiagnosed. And in fact, he actually did have, let's say, a lysosomal storage disease or an ongoing progressive neurogenetic
But
abnormality.
for lysosomal storage disease, you can't use autologous. Well, can you?
Exactly. No, you could not. I mean, the only way that you could use that is if you did a genetic manipulation and you corrected the abnormality ex vivo and then put the cells back. Which has been done. Bone marrow transplantation has used ex vivo cell therapy. But most of the time for lysosomal storage diseases, you would use a closely matched normal cell supply.
Yeah. Now, the last question, when people do the bone marrow transplant for autoimmune, when you were talking about this work with Joanne Kurtzberg, she had CD34 isolated, or she had the whole blood? Do you know, the whole Buffy coat?
For the experiment that I was talking about?
Yeah.
It actually was probably not fractionated.
Okay.
At the time when she was doing that, it was not necessarily fractionated. No.
Okay. No, the reason why I'm asking is I know in the type 1 diabetes, they have very well mapped susceptibility loci. And some of those susceptibility loci are associated with monocyte hyperresponsiveness or monocyte proclivity towards certain cytokine profiles. In the work of Richard Burt, where he's doing this autologous bone marrow transplantation, actually, no, that's autologous. I was going to say that if it's the microglia, but it's autologous, so they would still have the genetics, the genetic abnormality. Very, very interesting stuff. Well, Dr. Schneider, thank you so much for your help. Let's ask the audience really quickly if there's any more questions from the audience. We'll count to 3. 1, 2, 3. Okay, no more questions. So thank you so much, and let's continue these discussions because I think you have a lot of knowledge and depth in this space, and there's also a lot of very interesting clinical observations and different things that people are doing and have done. And it would really be nice to put together all these ideas with different clinical trials being done in the U.S. by people like Warren Sherman and Amit, and just pick your brain and you pick their brain, and we learn a lot about each other and about biology. So thank you very much, and thank you, audience, for watching.
Yeah, thank you for having me. I'd be more than happy to come back anytime.
Thank you very much, Dr. Schneider.